So I think the latest and most exciting data was actually our late-breaking abstract at ASH that was published. And so this was a BMT CTN trial 1703, and we have been waiting for this trial to produce its data for quite some time. But excitingly, actually, they were able to publish this data and present it a year before they were actually anticipated. So that's fantastic. And so this trial actually was a phase 3 kind of expansion trial of CTN 1203 that initially showed that in a reduced intensity matched donor setting, that post-transplant Cy was equal to our historical precedent, which was TAC methotrexate. And so a lot of institutions have kind of integrated post-transplant Cy within their prophylactic GvHD realm. However, I think the results of this phase 3 trial certainly kind of finalize that data that yes, post-transplant Cy does provide superior, not only GvHD prevention, but also relapse prevention. And it had an 18% benefit of GRIFs or GvHD-free, relapse-free survival. And with this novel endpoint, we want patients to not only survive the transplant, but also be without graft-versus-host disease and not be in a relapsed state. So certainly this is really beneficial for these patients. I think another very exciting addition to kind of the prophylaxis realm is Abatacept, which is another unique novel target that actually got FDA approved in 2021 for prevention of graft-versus-host disease. So a lot of the agents that we use out in the market are actually technically not FDA approved, and this actually became our first FDA approved agent. So that's very exciting. I think given its toxicity profile, it definitely has the ability to kind of integrate and add to post-transplant Cy, in addition to some of our other immunosuppressive agents that we use. It's very promising in the mismatched MUD setting as well as the matched MUD setting as well. And I think, one of the unique aspects, I am not a pediatric transplanter, but I have friends that are, and they're very excited about this because it actually has an FDA-approved indication in pediatric patients as well. And so certainly this would kind of bring patients that are a little bit younger, having less exposure to ATG and CAMPA, so those more hard-hitting T-cell depleting therapies. I think one of the biggest challenges is certainly that GvHD is not kind of a one-size-fits-all, and there's certainly a lot of considerations that we have. Some institutions kind of typically do bone marrow versus peripheral blood. And so finding kind of the nuances and splitting those hairs to find what's the best regimen for that patient, given their particular comorbidities, what stem cell source, what's the donor aspect, recipient aspect, to really kind of create a package for that patient based on their risk factors and what we're most worried about. And I think really kind of putting it all into perspective, when we're transplanting patients, we're worried about infections, relapse, and GvHD. So we're trying to limit all of those in the best way possible. And certainly I think some of these novel therapies are additionally kind of moving that standard of care.